We have with us in the booth our third keynote address. I have Dr. Amy Baughcum, Dr. Elizabeth Fischer, Dr. Lamia Soghier. Okay, and you all gave quite a collaborative keynote discussion on perinatal mood and anxiety disorders and how can we best support families in the NICU. And one message I really got across the different portions of the talk was how this is really a longitudinal thing that we have to do. I think a lot of units are trying to integrate small pieces, but it's really prenatal all the way through the admission to discharge home and beyond, because we know this is affecting families long term. So I don't know if you guys want to go in order of your presentations if you're comfortable with that, but give us what are the take home messages from each of your talks?
I'm gonna start with the fetal,
Mhm.
even though we presented it late. Dr. Joanna Cole was our featured keynote speaker, and she is the heading the fetal the psychology team in the fetal center at
Mhm.
the Children's Hospital of Philadelphia, and she gave a wonderful review of how her team has evolved. Um, and I emphasize she started off with a very, very small team, and now it's become kind of quite an incredible host of, physicians, subspecialists, psychologists, social work, all of the services that are needed, OT, that's kind of was a highlight for me that, you start small. And then she also highlighted a lot of the activities that she does, including bereavement. That was very powerful.
Yeah.
How she supports families through uh, big crises, small crises, including having a new diagnosis of a fetal problem.
Mhm.
Um, all of the different things that she can get into, including like family counseling, and then unfortunately some babies do pass, and she does some of the bereavement, and also her connections into the NICU world. So once you get in through the fetal clinic, you're also being followed a little bit in the unit. And we had some really good questions about the communication. I think there was a group of palliative care docs as well who are answering kind of um, how does the palliative care integrate with the behavioral health team?
Any tips for how to improve that communication?
Um, I think um, I think one thing I take away from all of this is it takes time and a lot of good communication and back and forth. Like you're not going
Mm.
to hit the right stride. Um, you're not going to get the perfect system from the get go. You're going to need a lot of trial and error. But as long as everybody's open and collaborative,
Mm.
um, which I also got from all of our speakers.
I love that. And I just to highlight some of those slides, it was, they showed, for example, a list of care appointments, right? You were screened, you got your echo, you saw social work, you saw the ultrasonographer, and you saw the psychologist in addition to the physicians that they were meeting in the prenatal clinic. And I think that is such a unique model, but I think makes plenty of sense why we would certainly need that. Um, Go ahead, E.
I think there's no perfect system, and so I think starting somewhere
Mm,
makes a difference. I mean, I think, you know, perfection is the enemy of the good. We need to start somewhere. We need to help these families be able to navigate these waters. It's very tough going for so many of our families. And again, there may be families that may be quiet, they may be compliant, and we're
mhm,
missing something,
mhm.
right? Um, because we're not asking the right questions. We're not approaching them and letting them know that their well-being is important. And so I think it's helpful when we have that institutional support and we are able to
Mm.
put forth time and effort, money, resources to help make a successful program, but definitely starting somewhere, whether that's screening, whether that's a part-time psychologist
Mhm.
who is available for those who may be at most risk, and growing from there. I definitely hear from my families all the time just how much they appreciate that level of support, that continuity of care, and following them all the way through.
Yeah, and your portion of the talk was the psychologist role in the NICU. And I really love how you highlighted parents with high levels of distress, because I recognize that sometimes the parents with some of these uh, signs and symptoms, mistrust, communication issues, these kind of they can be labeled as an angry parent, and so sometimes we are really the parents who need us the most. We find a way to alienate them if they've had some misbehavior, and I wonder how you can. Uh, Implore people to approach them more with curiosity than with, punitive.
I think that's a great way to put it. We have families from all different cultural backgrounds
Mm,
and all different histories, and this may be how they operate. Maybe they're more reactive. Maybe they've had a lot of trauma along the way, and I think it is part of our job is to help our team partner with these families and help understand where that might be coming from, and helping make sure that our families feel respected
mm,
and feel heard. So a lot of times I'm asking families, how do you feel like care is going? Do you feel respected by the team? Do you feel included?
mm.
And I can help advocate from there. I definitely think there's a liaison role to all of this where we really are trying to improve that dynamic between teams and families and helping build that empathy for these families. I know it may take a little bit of extra time at
Mhm.
rounds or whatever. They might need an extra phone call, but it's time well spent because I do think it leads to better outcomes and better partnership.
I think that can be one of the roles of psychology in the NICU, and is, I'm sure for you, it is for
Mhm.
me, being able to translate some of those behaviors into what they really mean emotionally,
Right.
and being able to say to the team, I know that this is a struggle. Here's the piece that maybe isn't quite as obvious, that will help you as you continue to work to communicate with this family and support them.
And again, speaking of that trial and error, trying to think like, well, if we try it, let's try it this way. If we approach
Mhm.
it from this way, what happens? We don't always have the answers. We have to try a few different approaches to reach families sometimes.
Yeah, absolutely. And for people who don't have the luxury, the privilege of having a psychologist embedded in the NICU, maybe you can talk about some of those practice care models. Do they make appointments with families? Are they there when just families arrive at bedside? What does that look like in those units? Maybe 40 or 50 units that have psychologists, those lucky units. What does that look like across the country?
All the above.
Yeah.
It's you said it in your talk today. It's
Hmm.
showing up, it's being present so that you're in the thick of it and able to communicate. It's um, being available by text message if somebody is really struggling and the nurse needs you to come to bedside now.
Mm,
Um, and it's talking to a family and saying, I can be available for you after work tonight. What time is good for you?
incredible.
I do think, for some of my families, they want predictability. They
Yeah.
want that control. I'm like,
Mm,
that's great. I'm one of the few things that they can control.
yeah.
And so they might just want a weekly timer every 2 weeks or
Mm,
whatever, just to check in. We go with the flow.
yeah.
And then most of the time, it's kind of on the fly,
Yeah.
where we try to circle around, we're rounding on the unit, we're
Checking
checking
in.
in every few days or so, and then just kind of following their lead. But there are models in which psychologists may be automatically involved with everybody or automatically involved with certain subpopulations or maybe responding to elevated screen results.
I love that. And I think to the end of your talk, you hit the nail on the head about how do we talk to our systems about the importance of the psychologist. It's not just a nice thing to have. Some of the good, important outcomes you had here and these responses from parents that having a psychologist helps me better understand my emotions and how to better cope with my child's medical illness, improves communication with my child's medical and surgical team, importantly impacts positively my satisfaction with my child's NICU admission. And some of those things are very important to our hospital C suites. And so, if some of the research around the importance isn't connecting, maybe trying some of those other approaches about patient satisfaction as a tool to
Yes.
get what we need.
Yes.
It's wonderful.
I think aligning with those institutional
Right.
priorities and helping to show that we can make a difference. And I think the more that we collectively as a field keep moving the ball forward and published so that people have concrete things that they can take to their administration.
I love that.
And we also have in our focus group, we've got big social work presence.
Mm.
And to your point about if you're not lucky to have a psychologist, we do what we've learned from all our groups is even the really well-resourced hospitals have variability in the psychology presence, how much FTE is so variable. So we're learning about each hospital individually and how to make it work for them with the resources they have. So, you can start small. Social work team has stepped up in our hospital, and they've been tremendous in getting things started.
Wonderful, wonderful. And let's move on. We've recognized a few times over the course of the last 48 hours interviewing people how discharge can be an especially emotional time for parents. And they expect that it's going to be all joy and rainbows. And that's typically not the case. There's a lot of anxiety, fear, loss of community. So tell us about that transition to home, and how does the psychologist play a role in the follow-up of NICU infants?
Yeah, so you're right. I think increasingly over the past few years, all been having these conversations
Mm,
of transition home is a pain point for many families that we are not adequately addressing. And ideally, we'd have these conversations with every family before they walked out the door.
mhm.
But that just with current things the way they are, that's not possible. So I do though try to talk to families before they leave if I can and say, this is a joyful time and many people feel lots of joy, but it's also okay if you feel scared.
Yeah.
And it's also okay if you're struggling, which at least opens up a conversation before they leave. And most parents will say, yeah, I'm joyful, but I'm
Mhm.
scared. And here's what I'm scared about. And here's the plans that I've made. And an opportunity to reflect with them on how well they know their baby at this point,
Mm,
what their journey has been like, how they know when their baby looks well, how they know when their baby doesn't look well, and reinforcing them as parents in their parenting role. And then, but the one of the big things is the trauma that we all know happens in the NICU, and high rates of trauma that really go past NICU discharge into the weeks, months, and years following a NICU stay. And I do try at some point during the journey to say, you know, you're probably not going to process this until you get
mhm,
home. And that's really when they start processing.
mhm.
That's when it all hits them. The adrenaline's gone
Right.
and
That
they're at
survival
home.
mode is
Yep, that survival mode is gone. And now we're at home. And now I've lost much of my support system from the medical team and the psychosocial team. And maybe having PTSD symptoms. I may be depressed or anxious or developing OCD, and I don't know what to do.
mm,
Um, so being able to capture these conversations in various parts of our outpatient care is going to be critical. I left here with lots of ideas from my friends and colleagues
mm.
about how I could work with our integrated behavioral health teams in primary care, for example, um, and then of course what we do in outpatient follow-up clinic and really making room in the outpatient follow-up space for family mental health, infant and early childhood mental health.
I love that. And I was very much intrigued by this slide about what are all of the things that you guys are tackling in the outpatient setting. Um, Obviously, continuing the screening, looking for symptoms, connecting to resources, but addressing sleep concerns, addressing feeding relationships, which we know is a huge deal for post NICU families, early childhood anxiety and fear. We know that anxious parents often have anxious children, and certainly dysregulated behaviors and emotions. And then this other ongoing monitoring, being part of that developmental monitoring team. I, it is different than what I had anticipated. So tell me a little bit about that.
Yeah, so and that's what I've done for much of my career is working with these very young children in feeding clinic or in general outpatient psychology settings where you are dealing with kind of normal developmental needs, and then we layer the NICU on top of that, and all of the medical conditions that may lead to delays um, or have their own psychologic co-occurring conditions. So some of our neurologic babies are obviously at much higher risk for autism and ADHD and dysregulated behavior, and all that comes along with that. And so being able, that is sort of the realm of early childhood and infant mental health, is being able to talk to parents about sleep, their own and their child's, setting up ahead of time for good sleep hygiene and trying to prevent the problems before they start when we can. Really getting them to understand what good eating relationship looks like and what good eating habits look like, just sort of at baseline. Now, some of these kids are feeding by tube feeding. And so, how do you work oral feeding in around tube feeding? They have specialists that they're working with around that. I try to support what those specialists are doing.
Excellent, excellent. Well, in the last few minutes that we have together, any words for the community about, again, the importance of this collaboration, checking in on our families, its impact on long-term outcomes? How can we really, push the community again to make this part a standard of care?
I think it's important, even just now, for our staff, our providers, to support families in seeking help, whether that's within the walls of the hospital or outside the walls of the hospital, to really normalize that it's okay to not be okay at a certain point, along this journey. But this is a lot, and to really normalize that and sort of destigmatize accessing care. And then the more that we know that if we can bring it to the families, the more likely they are to take advantage of those services and be more receptive versus having to make a special trip, or face other barriers to try and to link with outside help. But helping support mental health in the NICU at bedside.
I love that. So what I'm hearing you say is the low-hanging fruit, something we can all do in our units tomorrow, is at least say to a parent, these feelings you're having are normal and there is help for them. And lots of families need psychological services to deal with this traumatic episode. And can we help you with that?
And my favorite, you deserve to be healthy.
Yeah.
You deserve to have the happiness that you can with your baby.
Yeah, you mentioned that during your talk. I think sometimes we try to guilt parents into taking care of themselves because their babies need it, but you're right, as individuals, and I think what so often their individuality is lost in the NICU, right? They're on their way to finding their new selves, but that they deserve to have healthy mental health just by their own, person. I think that was something that I'll take home with me as well.
And my final thought is that neonatologists, I think, we're very we're very attuned to the dopamine and the medications and the TPN, and we work really well with our pharmacy. But I don't want people to be afraid to reach out to the psychology team, the behavioral health team, social work team, and I know people do it in psychosocial rounds and all of that. But the other big piece of it, please support them. If we're building programs, the best outcomes that we've had is when the medical team is standing right behind the psychology and social work team. And I don't think we do enough of it.
Yeah, my colleague Diana was saying that even if we are not taking on the role of doing the mental health work, all of us are responsible for helping our units have the best mental health support possible.
We need advocates and cheerleaders.
For sure. All right. Well, thank you all for this amazing, incredible work, changing outcomes for babies and families. Thank you for joining me.
Thank you.
Thank you.